For our first session, we are going to set the stage for providing a historical context in the opioid crisis and how DC is addressing it through the healthcare system. So we will discuss in depth the history of opioids in healthcare in DC, understand the context of cost communities, address the impacts of the opioid use disorder on marginalized populations, and discuss current policy implications. So to provide this context, we have invited Howard University's Dr. Robert Cosby, Dr. Janice Edwards, and Dr. Mark Johnson. Dr. Robert Cosby serves as an associate professor at Howard University School of Social Work. His research interests include opioid use disorders among older adults, gentrification and understanding the impact of social isolation and trauma on older adults, and the reintegration of older offenders into the community. He holds a master's degree in social work and social science from Syracuse University and a Ph.D. in social work from Syracuse University Maxwell School of Citizenship and Public Affairs. Dr. Edwards serves as an associate professor in the School of Social Work at Howard University, and she is the principal investigator of a Health Resources Services Administration grant, training social work students in behavioral health and OUD, SUD disorders in mentally underserved communities. Dr. Edwards' range of experiences extend from providing clinical services to inpatient psychiatric hospitalized children, adolescents, and adults to outpatient psychiatry to individuals, couples, and families. Prior to entering academia, she was the clinical director of the Emergency Psychiatric Response Team at the Federal Bureau of Investigation for 10 years. And finally, Dr. Mark Johnson is a professor and chair of the Department of Community and Family Medicine at Howard University and previously served as the Dean of the College of Medicine at Howard University. He is a graduate of Coe College in Cedar Rapids, Iowa, where he earned a degree in Black literature. He went to medical school at UMD, now Rutgers, New Jersey Medical School, and did his residency training at the University of South Alabama Medical Center. He is also a Robert Wood Johnson Clinical Scholar at UNC Chapel Hill. Thank you all for joining us today, and we will get started with Dr. Cosby.
Thank you very much, Eden. Thank you to Jackie Bowens and to your entire team. As was mentioned, you all have made it possible for us to be here today, and we're grateful. And so without further ado, we'll get right to it. I want to share my screen so that everybody can see that. And so we're going to do that now. Hopefully everyone can see the screen now. Great. We have had a bit of experience working at the School of Social Work in terms of looking at these issues of opioids and healthcare response. We have been able to work with we have right now, Dr. Edwards works with a HRSA grant on opioids and training individuals at the master's level to work in communities, and so you may hear her speak a little bit about that. So you heard Eden say a little bit about the overview of our presentation and sort of the context, clinical assessment, and some of the cost to communities, and then we sort of finished with some policy implications. Don't have a lot of time, so we're going to go through the screens fairly quickly. Since the 1930s, opioids have been around Washington, D.C. They have been in communities, entertainment, as well as a large presence in the Black community, but not just the African-American, Black and Brown community. In the 1980s, there was inexpensive heroin that flooded the area. It was mostly coming from areas of they used to call it the Golden Triangle, parts of Vietnam and the Burmese Triangle area. HIV infection made a big impact, and along with those issues associated with OUD and SUD, that they became real large issues, and so started to address issues of comorbidities for many people trying to look at survival in Washington. In response to that, the Department of Human Services, which had a commission of public health at the time, looked to do some very innovative things, at that time only happening in an area of pilot studies. First one, I think, was in New Haven, Connecticut. And so they looked at these needle exchange programs as a way to try and build on this level of expertise. And so they were able to do that. Is interesting with the District of Columbia because of our basically don't have the same representation in Congress. They don't have Congress representatives that can vote. The DC budget was held up by North Carolina Senator Jesse Helms. That had a great impact in terms of stopping some of the programming that we were attempting to do. Drug-resistant tuberculosis was also on the rise. In the 1990s, there were basically 3 hospitals that were working on these issues. DC General Hospital was the only public hospital at the time, Greater Southeast Hospital, and Howard University Hospital. So from the 1990s until the early 2000s, this became a big issue. It should be understood that there's a context for some of the closures of other hospitals around that time. Columbia Hospital for Women, which provided a lot of maternal and child care, as well as birthing for many mothers, many women of color. Capitol Hill Hospital, which was converted to a long-term care facility, an LTAC facility, and DC General closing in 2001. So this issue of opioid addiction and cocaine addiction, both smokable and injectables, became real big issues. Some people did the freebasing, which was also a big issue. And so many of these hospitals were relying on federal funding to be able to actually pay for that. EMTALA laws would basically say that they would have to treat people in emergency departments, but basically they were unable to do as much in terms of dealing with the medication and looking at some sorts of responses to that. There were no treatment facilities, so MAT was not really, there were, I should say, limited facilities, but many people that needed help were not getting that. And so what did that mean? That meant that parts of other parts of the city were not seeing the problem, but there were real big problems in certainly east of the river, parts of Northwest Washington, east of the river, meaning east of the Anacostia River and Anacostia and far southeast, some parts of Northeast Washington as well. Historic safety net providers tried to provide assistance, were able to do so, but created some issues. So what did the statistics reveal? They basically show us that, that there's a death rate in the District of Columbia that was higher. Most recently, looking at 2014, 2017 data, we can see that the opioid deaths were on the rise. You'll see why in just a moment. So prevalent use continued in terms of overdoses, wards 2, 5, 6, 7, and 8. Mayor Bowser did something which many of the public health folks were very pleased with in terms of being able to provide naloxone kits to police officers, metropolitan police officers, and they were able to provide this to individuals that needed that to prevent deaths. Under this plan, it was also expanded to where people can request kits, and they will be given to others if they need it. Perhaps we'll hear a little more about that later. Most prevalent, Ward 7 and 8, 2019. I believe it's still continuing. It's shown that the data most recently, I think, is a little trending a little lower, which is a good thing, but you'll hear more about the data in a bit. So what are some of the lessons learned? We can see that MAT programs definitely around the country are important. We can see that, that they have worked on working with people that have been incarcerated and returning citizens to look at ways of being able to help. We can see that there is a dramatic impact in terms of the drop in statewide overdose deaths because of the work that communities are doing, like Washington, D.C. And we can see that the MAT program is very successful if implemented and sustained. So basically what we're saying, without treatment, we will see many more problems. we see in this returning citizens, we see a lot of people that have overdosed, largely because they are unfamiliar with the potency of fentanyl. It is inexpensive and has in some places replaced heroin in its use. One of the deans in this area, Dean Edwin Chapman, Dr. Chapman, he's basically said that what we can look at is trying to end the stigma, look at treating addiction as a medical disease, initiate treatment in place of incarcerating people, looking at ways to better continue MAT without interruption, and being able to start MAT as soon as the emergency department, so that we post-resuscitation, so that people can look to try and work on treatment. So this is really a big issue as we talk about the integration of care, and we think this is important to look at the types of options that we can look at. Certainly during this time of COVID-19, telemedicine is really caught on quite big. Coaching and all of these are big pieces in terms of why we can do that. When we talk about who is at risk, as a gerontologist, one of the things we see, I see and am concerned about basically I work with the Multidisciplinary Gerontology Center at the School of Social Work at Howard. We can see that the numbers of older persons that are substance abuse users or substance users are seeing an increase in terms of OUD and SUD. And we see that because baby boomers are retiring at 10,000 a day, we see that this is a real issue. So I'll turn it over to my colleague, Dr. Edwards, and she can continue some of this discussion.
If we could just go back for a second to the slide in terms of who is at risk. One of the things that I would like to point out here is that if you look at who's at risk, we need to start raising questions about the short supply of practitioners that are providing care. In fact, that was one of the motivating factors for the HRSA grant that I'm the principal investigator on, is that they recognize that marginalized communities despite the numbers of physicians and practitioners and behavioral health specialists in the Washington area, the DMV, there is a short supply of these practitioners in marginalized communities. The other thing that we need to also keep in mind is the fact that gerontologists, and Dr. Cosby can speak to this as well, are also in short supply. And you'll learn later that there is a high incidence of, because of the treatment of pain, of opioid addiction among aging persons. The other thing is that, and Dr. Johnson, please correct me if I'm wrong with this, but we are now just really beginning to focus on physician training with an emphasis on addiction. And most importantly, in addition to all of these factors, what I want you to consider is that there are very few age-specific programs. And that's something that, I think that we really need to take into consideration from an advocacy perspective and funding perspective, particularly in marginalized communities. The opioid crisis has been really causing havoc in urban Black communities. I've referred to them previously as marginalized or medically underserved communities. And in addition to that, while marginalized urban communities are experiencing challenges, they are also experiencing challenges in rural areas. And what's worth noting is that the perception of the opioid addiction is a crisis of epidemic. We have a couple pandemics going on. I think this is a part of the pandemic crisis, and research is going to bear out what that pandemic is, what the interaction is with the increasing use of opioid addiction, and maybe Dr. Johnson can speak to that as well. We can go to the next slide, Dr. Cosby. So this year, DC's rate of drug overdose deaths third, I mean, this is a significant statistic, the third highest in the nation, and that's up from 17th. And again, what research will share with us is where we are as a result of the interaction of the pandemic that we're experiencing. And it's not just the pandemic of COVID-19, but of all of the issues that we're experiencing, particularly with racism and how people are responding to that. So going back, in 2017 in Washington, we had 244 persons that died from heroin. And also, we noticed that 14 states had significant increases in death rates that involved heroin. With Washington, D.C., Virginia, and Ohio, West Virginia, let me correct myself, because I think West Virginia actually was the highest. The next slide, please. The reason that we have this slide here is we had the opportunity to participate in the DC Council hearing on how we can address preventing more drug overdoses. So what I want to say to everyone is that our advocacy, our being present, our being there and articulating the concerns that we see as practitioners with legislators, and particularly, here in DC Council, this was a successful hearing because they added more money to be able to address this issue in the city. But we have to do it not only locally, but we have to do it on a national level. What are the policy implications? Purdue Pharma take-back program, and I think we all know about what's been happening in the news with the Purdue Pharma. I can't remember the amount. Dr. Cosby, do you remember how much Purdue Pharma had to pay in fines?
I believe they were looking at $250 million, about around there. But the problem is, well, I shouldn't say a problem, is they've been very clear in terms of being able to be helpful to legislators and to basically get them to see this in a very different way. And most recently, I believe their lawyers have been able to not be as aggressive as they were in terms of trying to take their money. Many of the principal owners of the company, the Sackler family, of the same Sackler family that gave money for the Sackler Gallery, part of the Smithsonian Institution in Washington, D.C. They basically put most of their money offshore. But that's a whole nother discussion. But what we're talking about here is the policy implications and the fact that Purdue Pharma now has a take-back program that they are working on, and that they have some aggressive opioid marketing for palliative care, for work with hospitals, with schools of medicine, and have provided great incentives for people to use their products.
So when you think about the implications here, what this says to us as practitioners is that we have to work with legislators. We have to educate them so that we can provide jointly solutions to this problem. And so here you see another chart where it just kind of goes into what's happening with heroin, fentanyl, carfentanil, synthetic opioids, and IDA. And what's important here is you see the growth. There's no decline, it's growing. And so it points out to the concern and what we have ahead of, to look for as this issue continues to mushroom. So why is there such a problem? Let's consider morphine. And morphine is made from opium poppy plants. It's a very bitter, crystalline, addictive narcotic base. I'm not going to go into the chemical formulation, but the issue is that it is very, very powerful. And so, you know, that speaks to the vulnerability to addiction with this particular drug. And the same with heroin, which is a morphine derivative, fentanyl. You notice here 50 to 80 times more potent than that of heroin. And then the carfentanil is a synthetic opioid as well. And I think this is the big boy. This is the daddy of them all, 100 times more potent. And this, as far as I'm concerned, this underlies why it is so difficult once patients become addicted to this. Dr. Cosby?
So basically, when we talk about opioid overdose rates, I should say, related to pain relief for prescriptions, particularly for older persons, this is a big issue. And we can see that the opioid death rate, as we look in this area, we can see that it is continuing to rise. But as we see the prescription rate, in other words, folks prescribing the scripts for this, like those for OxyContin, that was a primary drug for Purdue Pharma and some of the others, we can see that that there is still a great deal of death. When we talk about issues concerning opioids affecting children, we can see that there's also a big issue, and you'll probably be hearing more from Children's Hospital folks, and certainly probably from Dr. Johnson as he talks about community health and community medicine. But one of the issues that I wanted to share with you is this issue of HIV, and continuing to see that it has had an impact as it continues, and we talk about injectable drug use. And so we can see that there is a big issue there. Certainly among females, it's about heterosexual contact, and we can see that those are issues. When we talk about opioid-involved overdoses, we can also see that there are big issues here, and it's worth recognizing that this is something that we really need to get our arms around. And I applaud the District of Columbia and different responses from Department of Behavioral Health to long-term care ombudsman to the work of DC Hospital Association, and certainly DC government in large part, recognizing that this is indeed important for us to look at. When we talk about this issue of opioid-involved deaths, we can see some of the data, and you'll hear more about that in a little bit with the next presenters. But I wanted to sort of share with you what we mean when we talk about this issue of what do we do next. So we see that the opioid abuse is down for younger Americans, but it is rising for older Americans. Why might that be? Well, when we talk about older adults, we're talking about soon to be older adults, and we can see that these are some of these individuals who may have grown up in the 60s, 70s, 80s, who may be bringing with them a history of drug dependency. So these are ongoing issues. The most abused medications we can see, OxyContin, as I mentioned, oxycodone, hydrocodone, that was in 10 years ago approximately, and we can see now still OxyContin, still oxycodone, Percocet, Vicodin, but the new one is fentanyl, largely because it's very inexpensive, easy to make. The main suppliers right now come from China and bring them into this country because they make largely analogs of this. It's also interesting to note that the major pharmaceuticals are able to work on that. Dr. Edwards.
So you might ask, so what are the signs and symptoms that we must pay attention to when we're working with someone who is addicted to opioids? Confusion, depression, delirium, as you can see, insomnia, Parkinson-like symptoms, lethargy, loss of appetite, particularly concerning are issues around falling, especially with aging persons, as well as constipation and respiratory issues, and sleep apnea. So speech slurs, there's a lack of motivation, there's a memory loss that has to do with where it affects, where the drug affects, what area in the brain it affects. Then you can see relational problems and issues around taking care of oneself. And continued drug-seeking behavior. But most importantly, it's very interesting if you look at the data on doctor shopping. You know, the patients have become skilled at knowing who they can go to and how to go from one to another and make a mix of who they're seeing to get their medications. So it really requires us to do a lot more collaboration with our colleagues when we kind of pick this up and just checking back with whoever was previously prescribing. Now there are programs where you can see exactly what and who has been prescribing opioids. The issues associated with assessment and management are, when you think about pain, what we're learning is that there's a tendency to underreport in the area of pain. For aging persons, they might just say, well, it's just a part of the aging process. It's tendency, some aging persons have this tendency towards stoicism. Other persons may fear of addiction if treated. But this is not uncommon. Pain can contribute to worsening frailty, functional decline, poor appetite, poor sleep, and depression. So what it says to us as practitioners is that we really have to pay attention to how we perform assessments. They really have to be broad, and we need to dig deep so that we can understand the medical and the psychosocial issues that may be contributing to these factors. Now, the practice issues, is another issue that is a concern. What we do know from the research that Dr. Cosby and I have been working on is that there is significant disparities in assessment and treatment of pain and palliative care that causes consequences of unequal care. So what we need to do is there has to be much more rigorous research to develop interventions and practices. And let me say, back up for a second, that this research must be interdisciplinary so that we can together develop interventions and practices and policies where we can eliminate disparities in pain. For African Americans and Hispanics, they're more likely to be undertreated for pain than Caucasian patients. And racial and ethnic minorities, Black and brown people over the age of 65 represent the fastest growing population of opioid and substance addiction. And so we have to pay attention to that. It's estimated that, listen to this, by 2030, older minority adults are expected to represent 25% of the adult population. And healthcare providers are more likely to be treating this population. And so what do we understand about minorities and how we should treat minority populations that are addicted to substances? So I'm not excluding the fact that there are predictions for a rise in the addiction in non-minority communities. But I think that we really have to pay attention to what's happening in marginalized and urban communities where you see a larger population of minorities. In addition to that, we have to continue to work through the issues of understanding the clinical issues for older adults and pay attention to how, in our working with older adults, how they need to be treated and enhance the interdisciplinary collaboration. The last point on this is that what we know from our research is that Black patients and physicians were significantly more likely to state that they would switch to a higher dose or a stronger opioid for patients exhibiting challenging behaviors. The physicians, by the way, were white physicians. This adds to or deepens our understanding of some of the practice issues that we must pay attention to. So if you want to look at this word display, conditions that can present and lead to prescriptions of opioids are here, and there are quite a few. There are quite a few. There is one other point I want to make, and that is that, and I would be remiss, I have a daughter that has a doctor of physical therapy, a DPT, and I've invited her in on some of the research we're doing, such as, looking and viewing patients in marginalized and urban communities. And what she said to me is that there really needs to be a pull-in with physical therapy, because physical therapy can be an adjunctive use for management of pain and helping patients work through pain. So I think we ought to include them into the fold of working towards addressing the pain issues related to opioid addiction, or that can lead to opioid addiction. Thank you, Dr. Cosby.
Thank you. In the interest of time, I just want to make you aware of a case which may stimulate some of your thinking as we talk about older persons. And this is an instance of an 82-year-old woman who was prescribed OxyContin, which she's filled religiously for 6 months for pain, back pain. She now says that in addition to that, she's taking SAMHSA for depression, and she is committed FD12 to a hospital. And while in the hospital, you're asked to assess what might be the issues associated with it. What would be your overall diagnosis, and what might you do in terms of working with her or getting her the type of care management necessary? What would your care treatment plan consist of, et cetera? So I want you to think about that. We have only a limited amount of time. I'll just go through the slides very quickly for Dr. Edwards to sort of look through and tell you that some of these things that we are talking about in terms of opioid abuse treatment, they are quite important. And so we have some other pieces, some treatment scales and some other types of tools that you may want to use as we talk about this. And any other last points you'd like to make, Dr. Edwards, before we turn things over to Dr. Johnson?
Oh, absolutely. The tools we can provide to you, but they're important for assessment. But what we have to keep in mind are the comorbidities. Many of these patients present with multiple medical conditions, cognitive problems, some of which are related to the fact that they're on opioids and other substances. The mobility problems, which I spoke to earlier with respect to pulling in another discipline to help work with some of the motor or mobility challenges that our clients are experiencing. Here's a toolkit again. We have to think about interdisciplinary programs. I can't emphasize enough, we need to pull all of the disciplines in. It has to be physicians and nurses and psychologists and social workers and physical therapists and nutritionists. Nutrition has a lot to say about how you help clients that have become addicted to opioids.
So the last point I wanted to say is that we've shared with you a fair amount of information quickly related to the history, some of the clinical assessment issues. These are some of the scales or tools that you may want to look at in terms of looking at opioid risk, as well as some issues. And so we have a variety of references as well. And hope you found this information helpful, and that you will be able to be equipped in the days ahead for the rest of this conference and afterwards when you get back to your practice or to your working relationship or to your caregiving, to recognize that these are important things. At Howard University School of Social Work, we're here to help, and we are glad to see that the DC Hospital Association has asked us to partner with them in presenting to you today. So back to you, Dr. Johnson. So I'll stop sharing my screen and you're up next. You're on mute, Dr. Johnson. There you are.
Good morning. Hold on just a minute.
You want me to pull up your slides for you?
Yes, please.
Okay.
There you go. Thank you.
Yep. So just tell me when to move them slides, and I will advance them as you need.
Thank you very much. Good morning, everyone. It's a pleasure and privilege to be invited to present to this group. What I want to talk about today is a specific initiative that was started about 5 years ago at Howard, as a response to the opiate problem in our community. We've had funding for this project from the Primary Care Bureau of DC Health and from HASTA. Next slide. And overall, the Urban Health Initiative, which is what we call our project, is a multidisciplinary collaboration between people at Howard and the many community-based organizations in order to make sure that people in need get primary care, behavioral health, and care coordination, particularly patients with opiate addiction. The goals of the project was to improve access to care, improve overall health of the community, and to reduce the per capita cost of care. Next slide. So historically, I should let you know that this was started by Dr. Algotu and Dr. Adenuga at Howard. And this was started in 2014 while I was still dean. And they saw it as an opportunity to provide some of the gaps in care to patients who had opioid use disorders. And what the program does is it will do an intake assessment to find out where the patient currently resides as far as their opioid use, whether or not they have access to primary care and behavioral health care. Each individual person gets assessed, gets a treatment point that is discussed by the team. We try to get them a medical home so that they can get primary care and prevention. and in a psychiatric home, we found that at least half of the patients that we see with opiate use disorder also have a coexistent psychiatric illness, and part of their problem has to do with their treating their psychiatric illness with street drugs. And next slide. One of the principles that we use for our work and for a lot of the new work that has been done in the past 10 years or so is there's this issue of harm reduction, which is a way of meeting the client where they are, rather than trying to pigeonhole or force the patient into a particular treatment regimen. The harm reduction philosophy, if you will, has some criticism. People will say that patients with substance abuse disorders really have a weakness, and if they overcame their weakness, they would be able to overcome their drugs. We've seen for many years that does not work, or it works for a small portion of the population. The other criticism that we hear a lot is about medication-assisted therapy, saying that you're basically substituting one drug for another drug, and again, if the person was strong, they'd be able to avoid drugs altogether. The harm reduction model basically says that, you know, if we need to provide people with as much resources as possible to decrease the possibility that they're going to get HIV, or they're going to become a sex worker and spread sexual transmitted diseases or hepatitis C, etc. And so that's the philosophy that we use in our program, and I thought it was worth mentioning here. Next slide. So the target population for the Urban Health Initiative are people with on medication-assisted treatment. We cover all wards of the district, and we're currently caring for a little bit more than 127 patients. So again, you know, they get care coordination at intake. You know, we let them define what their priorities are, and then help them obtain that. Next slide. So the outcomes that we're trying to get is we want them to be in an opioid treatment program in a sustainable manner. The longer we keep them in treatment, the less likely they are to overdose, the less likely they are to get HIV or to some of the other infectious diseases that are related to opiate use disorder. All of our clients are connected to primary care. You know, these patients, just like anybody else in our community, can have high blood pressure, diabetes, arthritis, etc. And these take a burden, and in some ways make it more likely that the patient will stay on street drugs. And so getting them the care that they need is important. We want to reduce hospitalizations, we want to reduce emergency room visits, increase medication adherence, and I already mentioned provide them with a medical home and a behavioral health home. Next slide. The barriers to success are many. And if you look at this list, virtually every single one of these is somehow related to what we call the social determinants of health. So, you know, patients will say, you know, if I had housing, I could come to my appointments on a regular basis. If I had transportation, I could get to my appointments. If I had a job, that would give me a sense of well-being, maybe a different medical insurance, and that would help me stay on track. And so our care managers work with each individual client, let them define what their priorities are, and then we help them get that. We have several clients who have were incarcerated and come back into the community, and that has not been a smooth transition for some of them. And I know for a fact, because one of my peer support specialists is involved with that, and other friends in the community, the district is actively working now to improve the post-incarceration to transition. The next slide. One of the things that I wanted to highlight, and you heard Dr. Edwards say numerous times in her presentation the importance of interdisciplinary collaboration. We at Howard have a broad variety of community partners who help us. They refer patients to us. If they have a strength in one of the things that our patients need, then we know that we can send the patient to them. And so this issue of community partnerships so that we can share resources is huge. And next slide. Another thing that the city has been promoting recently is the concept of a certified peer support specialist. And the peer support specialists are people who formerly were having problems with substances, are now, and I don't particularly like this word, but you know what I mean when I say clean. And they go through a training that's provided by the district to help others who are where they were navigate the process to recovery. And I currently have two peer support specialists working on my team, and I have to say that they have been invaluable on multiple levels as far as helping us help the clients that we are working with. The peer support specialists do peer support groups, and most recently we have started a female-only peer support group because we have been told that in mixed groups, often males dominate the discussion, and some of the male issues that are discussed are not pertinent to what the females' priorities are. And so there's been a very good uptake in participation in our female-only peer support group. Our peer support specialists do Narcan distribution in the community as part of their community outreach. They have helped us define a process for re-entry into the program for patients who have been non-adherent to the regimen. And they provided clothing to the participants. So it's a very hands-on process, even in this COVID environment, to try to get the patients the support that they need. We're in the process now of getting a new telehealth platform that the peer support specialists will use to be in constant touch with clients. And next slide. I wanted to note for those of you in the audience and community that at Howard, we have just started an addiction medicine fellowship. We were fortunate enough to get HRSA funding for this too, and we now actually have two full-time addiction medicine fellows, that are working with the Department of Psychiatry and Family Medicine and other departments. By 2022, we hope to be able to expand from 2 fellows to 4 fellows. But we're pleased with getting this support and adding this training for people here in the community. Next slide, please. I also wanted to mention our ECHO program. ECHO is a program that was started at the University of New Mexico. It was started by hepatologists who realized that people were dying in his state because there were very few hepatologists that were seeing patients with hepatitis C. And so he put together a online mentoring program for primary care physicians around the state to teach them how to provide care to this population. And it was very successful. And he measured success because the wait time to see him went from 3 months to 2 weeks. And so he has expanded this not only around the country, but now around the world as a way to do online mentoring for physicians and other clinicians who are providing care to a particular population. And so we have been providing a project ECHO for opioid use disorder here in the district, and twice a month we have programs that teach some type of aspect of care to opioid population. It usually starts out with a case presentation and then a brief didactic presentation with the discussion. So I wanted to let you know that this was also on the menu of activities at Howard. The next slide, please. This is just the members of the Urban Health Initiative team, including a list of the MAT providers in psychiatry, in anesthesiology. And so I believe the slides will be available to you afterwards in case you wanted to get in touch with any members of our team. Next slide. This is the pictures of the participants on the health initiative. And I have to say, as the leader of that team, that I'm very, very proud of the team and the work that we're doing in the community. And next slide. So I'll take this opportunity to say thank you, and we can answer any questions that you have.